Morning, Melissa.
Hello.
I call you Mel, don't I?
Yeah, that's fine.
I'm Lisa. I'm a surgical educationalist, and I work with KSS, particularly on the leadership program and the induction program. Would you introduce yourself, Mel?
Yeah, hi, I'm Melissa. I'm one of the CT2s in trauma and orthopaedics in Brighton at the moment.
And can you tell us a little bit about how you got to be a CT2 in T&O?
So I studied medicine at Barts after doing a degree up in Newcastle before, and then did my F1 in Hastings and loved it, and started my first job was in general surgery and absolutely loved it there. It was a great team. And then went back to London, into Woolwich to do my F2, and didn't like London so much, so I thought for my CT1 and CT2 I definitely wanted to get out of London again, and I knew that the trainees in Hastings had a great time, so that's why I put my CT1 job top as Hastings. I went into it thinking I want to do general surgery, this is what I want, and I knew that that job was great. So I started off the year in CT1 as general surgery, and then my second 6 months was in trauma and orthopaedics, and that completely changed my mind. And I changed my CT2 job to go from general surgery to trauma and orthopaedics, and hopefully that's where I'll get a registrar job in the future.
Well, what was it? What was it that changed your mind?
I think I'd had enough of looking at bums and looking at bowels, and I didn't find the surgery that interesting when I was in there, whereas when I got into orthopaedics I just got a drill and in my hand and I loved it, and it was just really fun. I found all the operations really fun. I like looking at these x-rays and thinking what can we do to fix it, and then going into surgery, fixing it, and then seeing immediate results straight away, and seeing these patients leave the hospital significantly better than what they were, whereas general surgery people get very sick, it takes a long time for them to get better. So I just like the quicker turnaround and the more hands-on approach to it as opposed to general surgery.
Okay, great, thanks. So you are a CT2 now, and a lot of our viewers will be at the start of CT1.
Yeah.
So given you've already been there, what are the kinds of things that you really wish you'd known at CT1?
I just wish I'd been a bit more organised and started my logbook much sooner. Start it as soon as you can, because that means you don't have to go back weeks when you did operations and try and find which list you were in and put those details in. So start it as soon as you can. I didn't know that you could put for one operation, if you did two different things like an MUA and then a KY, you can put that down as two operations, so you get your numbers up a lot quicker. Starting your ISCP logbook much sooner, sending things off as soon as you do it, or with that person when you're getting a sign off, is much quicker instead of hounding them to sign it off for you, because they can just put their password in straight away at the bottom of the page once you've filled in all the boxes, and then you know it's done, you don't have to chase anyone. And yeah, I think that'd be my two things to
why do you think, looking back, what do you think gets in the way of people starting their logbook and gathering their work-based assessments and engaging with ISCP more quickly?
I suppose, especially for me, I found the start of CT1 quite full on. It was quite daunting. There was a lot of things to get on top of. So one, you're a CT1 and people looked up to you, especially if you're doing ward rounds with your juniors. So I found that quite stressful. I wanted to be on top of that, know my patients really well and know what to do for them. Then you're trying to make good relationships with your bosses, with your registrars, to make sure that you get the operative time and get into clinic and that they trust you. So you spend a lot of time doing that. And then what I found was I was saying yes to everything. So someone was like, do you want to get involved in this audit? Do you want to do a bit of research? Do you want to do a bit of teaching? And then try and revise and do my exam at the same time, instead of taking a step back and thinking what's the most important thing at the moment and organising it a bit better and thinking, yes, my exam's really important, so that's what should take priority, and then also get on top of the logbook and the work-based assessments. And then your relationships will develop and on going through that, not relying on yourself, knowing that you should be an amazing SHO and know all the answers on these ward rounds, or knowing all the answers in clinic, or knowing how to do every single operation. That's okay, we're all trainees. We will get better. And I found over CT1, my abilities got better, my knowledge significantly increased. So I think not to expect everything to be amazing right at the beginning and to know everything right at the beginning, just to be organised and to prioritise things, I think is really important.
So if you were going back now and you knew you needed to gather your work-based assessments and gather your logbook, sort out your logbook really early, what system could you put in place, do you think?
I don't know. I suppose talking to CT2s, especially in my trust, really helped, because they were, obviously they'd been through it before, they knew what was the important bit. So I spoke to a lot about my CT2 that was on my general surgical placement. And he sat me down and walked me through ISCP, because it is quite a confusing website. So taught me how to use it properly and told me which boxes to fill in and when to do it and which category of thing to fill in for each thing. So a WBA or a PBA or a DOPS instead of a PBA, and knowing when to use a KEX or a CBD. That was really important for me.
Is there, at the moment, is there a linking up of CT1s and CT2s formally, or did you?
I don't think there is, actually. It's just my CT2 was quite hands-on and really proactive with, because there was one CT2 and then 3 CT1s, and he did actually look after us quite a lot. But I think I don't think we need an official linking up, but just knowing that your CT2s are there and obviously are more than happy to help and explain things, and don't be afraid to ask any questions, because no one knows how to use the system when they first start, because it's completely different to what we've used before.
So maybe not necessarily creating a formal system, but just making sure that CT2s expect to provide some support to the CT1s closest to them, and yes, CT1s need to expect to do that. That sounds good. And just, yes, as you said, being organised and maybe putting a slot aside at the end of the day or at the end of the week to just make sure you've got stuff organised and it's not left until trying to mither people for assessments and validations must just be a nightmare.
It is. It's horrible, especially when you're applying for your CT2 job rankings. Obviously you want the maximum amount of points, so people are just scrabbling around everywhere trying to get those sign-offs. So just get started as soon as you can and just work methodically. Every on-call you do, at least get 2 or 3, and then you'll be well on track to finish it before any deadlines, and especially ARCP.
That sounds like a good idea, actually. Just setting your own target of 2 or 3, if you're doing an on-call, will give a really nice spread, and that will reflect well in your portfolio, because portfolios that have got wadges of assessments all around ARCP times or meeting times always ring alarm bells. So a nice even spread that show development sounds really good.
Exactly, and that's what they want to see. They want to see development. So you might start off, if this means something to the CT1s, but as a level 2, so you need guidance for lots of the steps, and then they want to see that at the beginning, but then also to progress to a level 4 by the end of the year, where you're able to do things a bit more independently. And I think that's a really good progression to be able to see on your ISCP.
I suppose that's a way of looking at your portfolio. I think Tanya Sarkel talks about feeding your portfolio, and they are not just to show how amazing you are. They are designed to show that you can squeeze the juice out of your learning opportunities. So as you said, you're not expected to start off brilliantly, but you are expected to demonstrate some progression. Can you think of any other ways that trainees can pick up points that will be useful to them later?
So especially for CT2 job rankings, because they don't publish what the points are worth before, until a few weeks before you have to put your job applications in. So just the most important things are to get the courses booked up, and I know that's going to be incredibly difficult now with the COVID, because even I'm struggling to get my ATLS. But try and get your ATLS and your CRISP. Try and get your exams done as soon as you can, because you get extra points for them. Make sure you go to prize day, which is normally in January, and submit something to that, because you get points for going, submitting, and then if you get a poster or a presentation, you get extra points for that. Get involved in the teaching that anyone you can set up in your local hospital, just teaching either F1s or medical students when we get them back, and then starting a really simple audit that you can close the loop on as quick, just do a quick one that doesn't require too much work, and then at least then you'll get maximum points for it. by the time job applications come around, and by the end, I think it's May time in CT1. Yeah.
So even this, you've taken time out of your day off today to do this with me. Mm-hmm. We can turn that into currency for you and your portfolio.
Yeah.
How best might we do that, do you think?
I don't know what I was.
Okay, so I'm just thinking, as we're doing this now, we can turn this into something useful for you. And you've taken the extra trouble, you've prepared for it, you've really thought about helping CT1s coming behind you.
Yeah.
So I'm wondering where we can put that in your portfolio. And I think there's a number of places. We could consider doing an observation of teaching, work-based assessment.
Yeah.
Which is a very different way of teaching, but that's exactly what it is. It's about development and teaching. We could do that. Mm-hmm. Or you could make me a clinical supervisor temporarily, and I could do just a paragraph about what you've done and why that's important. And that will then be seen by your educational supervisor. We could do a case-based discussion. Mm-hmm. Case-based discussions don't just need to be about patients. They can be about events. They can be about experiences. When you do your ATLS course, doing a case-based discussion based around what you learned and how you're going to use it. So there's loads of different ways of using your experiences and recording those and making sure you turn them into something useful.
Yeah.
By feeding your portfolio. So I'll leave that to you to decide what will be most useful to you.
Yeah.
And you then just need to tell me how you want to handle it, and then together we will make sure that's captured for your portfolio. Mm-hmm. Now, tell me about how you manage situations where you feel you aren't getting the opportunities you require, whether it's going into theatre, mm-hmm. or clinic, or exposure to specific clinical nurse specialists or plaster techs or orthopaedic practitioners. How do you manage that?
So I think it's really important to meet your supervisors as early as you can. So meet your educational supervisor and meet your clinical supervisors definitely in the next week or so, if you haven't done already. At least then, because then they'll know who you are and you can explain to them what you want to get out of this placement, what your experience is now already, and then where you want to be in 4 or 6 months, depending on how long your placement is. And then obviously now you've established yourselves on the road, you know what your responsibilities are. If you're not getting enough time in theatre or clinic or anything else that you want to do, as opposed to just being on the ward and doing jobs, then flag it up as soon as you can. So flag it up to your educational or your clinical supervisors and say, this is not appropriate. I'm not learning the things that I should be learning. And then you can also go to your guardian of safe working hours, and everyone in the hospital will have one. If you're working over hours and you're not getting paid for it, absolutely exception report it. I think the rep applications have gone out. So once you've got your CT1 reps, speak to them, and then they have direct line of communication with Ms. Sharp. And then if it's a problem even before they are established, then email Ms. Sharp straight away, email anyone else that's in the TPD team. And at least then as soon as it's flagged up, they know about it, because they might not know what the problems are with that specific placement or the rota or the things that COVID have done to that specific placement. It might have all changed, and you might be still on an emergency COVID rota, which may not be appropriate anymore. So I think don't be scared to speak up and say, this isn't right. I should be getting trained at the moment. I should be getting into theatre, because you are a core trainee now. You are a surgical core trainee, and that is what we need. You need to get your numbers. So I think they've changed it now to 150 numbers for the year. And you need to get those before ARCP. It's not that an ARCP is early in the year. It's May to June time. So it's not a whole 12 months that you get to get those numbers. And you want to, when you get into your ST3 jobs, whichever specialty you want to go into, you want to know that you want to have the basic knowledge of how to run a clinic and what the common presentations are there. So getting into a clinic as soon as you can is also really important, and make sure that's you're being provided that time to go there, even if it's just for half the clinic. It doesn't have to be for the full morning or full afternoon, just to see a couple of patients and get the feedback from the registrar or the consultant that you're working with about how to run the clinic a bit quicker, because it still takes me too long to go through a patient, but getting that experience is better than never going to a clinic before you're an ST3. So I think if there is a problem, just flag it up as soon as you can, because that's the only way that things are going to change. No one knows what the problems are until someone says it.
Why do you think people are loath to exception report?
I think when it first started, I think I was on F2 when it first started, and I think maybe more of the seniors were a bit against it and would badmouth people that did it. But now I think the attitudes are changing, especially I met my educational supervisor the other day who said, exception report everything, I don't mind, do it. I will sign off anything that you put in. So I think those attitudes are changing. And people don't want to see that they're complaining. They want to, obviously we all want to work hard and look after our patients, but there is a limit to what that is, and we should be getting paid for any extra work we're doing. I think it's a really important thing to do. And it also shows that if there's gaps in the rota and you're having to fill them, that's not fair either, because you've got so much other stuff going on outside of the 9-to-5 job. Like I said, that the exams, the courses, the teaching, the audits and the quips that you have to do to be able to progress through to CT2 and to get a job as an ST3. So I think it is important to know that exception reporting is fine and it should be encouraged everywhere.
Yeah. Okay, good. And what you said was making sure that you are accessing the opportunities you need to fulfill curriculum requirements, and that's really important, because of course the curriculum is going to change August 2021, so yeah. Making sure that those 5 capabilities in practice, the getting into theatre, getting into clinic, managing inpatients as well, yeah. And managing on take and working with the multidisciplinary team, making sure that none of those capabilities are neglected, and keeping a close eye on that balance. And of course, that will be an individual's responsibility. Mm-hmm. And we talked about really analysing the experiences that you're coming into CT1 with, what you already have, mm-hmm. and the gaps that you really need to start working on, and making those very explicit for your supervisors, whether they're educational or clinical supervisors. Yeah. So you're helping them to get you mm-hmm. really quickly and understand what you need and how they can help you, and constantly revisiting that. And that is important. Nobody else will do that for you.
Exactly.
So any CT1s, CT2s, actually any of us really need to take control of where our learning needs are, and be not just waiting for opportunities to fall from the sky, but asking for them.
Definitely.
All right, great. I think we've come to the end. Is there anything else that you think our CT1 listeners might need?
I think it's really important. If you don't know what specialty you want to go into and you're worried about it, that's fine. Like I said, I started off thinking I want to do general surgery. This is 100% for me. And then having a bit of a massive change of heart halfway through it, because I wasn't enjoying it, and being really worried about that, and finding work quite stressful because I didn't know what I wanted to do. But it's fine, and you will find what you want. Just focus on the things that you know that are important. So like I said, the exams, getting an audit, getting equipped, doing teaching, because all of those things still count to whichever specialty you want to go into. And you can always swing things that you've done to whichever specialty you decide that you want to go into. And I also think it's really important to not take on too much. I'm very much a yes person, so I say yes to everything that people want me to do. So I found at the beginning that I had so many things that was on my list. But just learn to take a step back and say, yes, I'd be really happy to help with that, but I need to get X, Y, and Z done first, and then I can help you. So they'd be my 2 very important things to finish on.
Great advice. Mel, thanks so much.
You're welcome.
Your thoughts, your wisdom, your reflections, and very best of luck with the rest of your career.
Thank you very much. Thanks.